My name is Stan Weisner. I direct the Behavioral and Health Sciences programs at UC Berkeley Extension. And we have a range of behavioral sciences programs, including public health, mental health, social services, addictions counseling, and so on. And there's some material out there hopefully some of you have seen. We cover the range of issues, looking at presenting problems from mood to anxiety disorders. Not that any UC Berkeley students or parents face any of those issues. And cover issues around aging, child-adolescent issues, neuropsychology. And we've just started this very popular series on health advocacy, which is helping to train people who want to assist patients and their families as they begin to negotiate what's becoming an increasingly complex healthcare system. We're in an aging society, as you all know, and the challenges of dealing with long-term care will continue to grow. So we urge you to look at our materials. There's some great courses, workshops for mental health professionals, mainly by two psychology professors on campus, one on aging in the brain. And as you're a parent, that becomes more and more of an issue as you become an older parent, and one on understanding human emotions. There's also actually a Stanford professor doing something on DSM-5, which is the Diagnostic Statistical Manual. This May 11th. We sometimes bring in people from other universities, even that one. So with that, as a part of the efforts by our Dean's Office to support these kinds of public lectures, this year, as you can see, we're doing it concurrently with Cal Day, and I'm very pleased to welcome some of the parents here and some of the audience that comes to extension courses anyway. And today's speaker, who I'm now going to introduce, is addressing, I think, one of the most significant social policy advances in a generation. Professor Dow is the Henry J. Kaiser Professor of Health Economics in the School of Public Health's Division of Health Policy and Management. He chairs the Health Services and Policy Analysis Graduate Group and serves as Associate Director of the Berkeley Population Center. Professor Dow has worked with both Democratic and Republican groups on health sector reform proposals at the federal, state, and local levels. Now, that's the kind of coverage and openness that I think we need more of in this country. He's also previously served as a senior economist for health at the White House Council of Economic Advisors. He's a recipient of numerous awards and honors, including the 8th Annual Kenneth J. Arrow Award for a paper done a few years ago. Recipient of a number of prizes for his work. He referees journals in a variety of fields, from health economics to health policy and planning, International Economics Review, the Journal of Health Economics, and I could go on. His research and teaching interests are, as one would presume, in health economics, international health, and economic demography. So we're pleased today to have Professor Dow with us and to be here, especially with us on Cal Day. So with that, I'll let Professor Dow step forward. And I think he'd like you to hold your questions until the end. As you might have realized, we are taping this lecture today, and it'll be on our website. So when questions come at the end, I'll be passing this mic around. Professor Dow.
Great, thank you very much for inviting me.
Thank you for coming.
So thank you all for coming out. It's such a gorgeous day, an incredible Cal Day. I was very lucky, and maybe you all wanted to sit down for a little while instead of sort of wandering around outside in the beautiful day and seeing so many other things. But we really appreciate you coming out tonight. I think it speaks to the salience of healthcare reform issues in this country, that people sort of want to spend their time on a beautiful afternoon sitting and chatting about these issues. So I'm just curious, how many people here are sort of parents of a sort of Cal? Okay, a bunch of parents here. How many alums do we have? A whole bunch of alums in the audience. So welcome. Welcome back. I just love to see that continual connection with Cal. So, my appointment is in the School of Public Health, but I am trained as a health economist, or trained as an economist originally. So I'm curious, how many people here have taken a basic economics course at some point in their so a lot of you, that's great. And presumably a lot of you at Cal, so of course you remember it all and you learned it really well. So I always like to start out just by giving a little bit of a test here to make sure that you guys really got it and remembered it. So I'd like it if someone here could share with me what they remember about what the first law of economics is. Supply and demand, okay, so that's sort of one potential law of economics. But remember, the first law of economics? Nobody. Oh boy. Maybe those of you who took economics didn't take it here at Cal, so we're okay. It took it down in the peninsula somewhere, and it's one of those other schools. But no, the first law of economics, just everyone I used to say get out your pencil, but get out your iPod or whatever, make your iPhone and write this down. So for every economist, there is an equal and opposite economist. Okay? For every economist, there's an equal and opposite economist. Right? This speaks to the huge differences of opinion that we see in U.S. society, but also among sort of academics and the so-called talking heads, et cetera. Right? There are huge differences of opinion. Anyone remember the second law of economics? Well, if you didn't remember the first law, I'm sure you didn't get the second law. All right, so I'll write this one down. So the first law is for every economist are equal and opposite economists. The second law, they're both wrong. Okay, so I think there's a great deal of humility we always have to have when we're sort of talking about sort of analyses of sort of public policies, et cetera, because there's a great deal that's sort of unknown, and it never ceases to amaze me with what supposed confidence people promote their particular sort of worldview and how everyone else is completely wrong. But economics, we can sort of do that. My father used to tell me, I remember when I was a kid, before I knew I was going to go into economics, he used to tell me about his economics professor who would put the same questions on the exam every single year. He would just change the answers. Right? And then, of course, there's the standard joke, if you laid all the economists in the world end to end, and they would never come to a conclusion, right? So, and then there's the one about President Truman, who asked his advisors to find him a one-handed economist, because his advisors, his economics advisors, kept saying, well, on the one hand, this could happen, but on the other hand, this could happen, and he wanted the answer. Right? Well, in the spirit of Cal's DNA of equal opportunity, as was mentioned in the introduction, I have worked with both Democratic and Republican groups at sort of all sorts of different levels, and I may, in an equal opportunity way, offend each and every one of you at some point in your sensitivities and challenge your preconceived notions about sort of what is right and wrong in the healthcare world. And I wouldn't be doing my job if I didn't sort of challenge everybody to sort of rethink something about what they're doing. So with that disclaimer about where I'm headed, let's go ahead and begin with just a simple overview just to remind ourselves of what's in the Affordable Care Act, the ACA, as it's often referred to now, popularly referred to as Obamacare. So the ACA was legislation that was that was signed into law in March of 2010, and the Supreme Court sort of upheld almost all of it last June of 2012. To date, there have been a number of features already implemented. So one of the big political wins was making it possible for dependent children to stay on their parents' health care insurance plans, for example, through their employer until age 26. So we have actually seen millions of persons now on their parents' health care plan. There are various estimates of how many of those actually were uninsured previously, but maybe a couple million of those are actually now newly insured who otherwise would have been uninsured without this. So that's been sort of a real win. It's helped a whole bunch of folks very early. A second win was banning so-called pre-existing condition exclusions for children. So requiring insurers to insure kids no matter what health conditions they have. So previously, there were many sort of documented cases of children needing health insurance and the insurance company saying, no, you're sick, we don't want your kind, or if we take you, we're going to quadruple the premium for you. So banning those kinds of activities polled very well consistently throughout all of the sort of healthcare reform debates, and so that was another sort of clear win. There were sort of a number of other features to help chronically ill individuals while we're sort of waiting the big push for healthcare reform, which is going to happen in 2014. So there were so-called high-risk pools in every state, which got extra funding from the federal government to help provide state-sponsored insurance for people who are already chronically ill and enable them to buy health insurance. Things like lifetime caps on insurance are sort of common, have been common in many insurance policies. So if you spend $1 million, you have some really serious illness, you get up to the $1 million cap and they say, oh, I'm sorry, we're not going to pay anymore. You had a lifetime cap on your insurance. You know, we call that sort of anti-insurance provisions, right? And you want insurance for the really catastrophic things, and many policies just would cut you off at a certain point. So those have been banned. And so many policies, except some that have been grandfathered temporarily, have gotten rid of those. Preventive care is now being provided at zero cost as part of the law. So another sort of good thing that is helping people. For small businesses, there are various tax credits that have been put on the table to help them buy health insurance for their employees. So far, actually, relatively few small businesses have taken advantage of that, and it's been really complicated, and it's not so the greatest PR win for implementation. And one of the other things that has received a lot of attention is the so-called 85% minimum medical loss ratio. So what does this mean? It means that insurance companies, they take all the dollars that they have collected in premiums, they need to pay out at least 85% of those to healthcare providers, rather than using it for profits to pay administrative overhead, et cetera. So there's some insurers who would commonly be only spending, say, 70-something% of their total premium dollars on actual medical care. And this has been something that some people have protested against because the high perceived profits of health insurers. Actually, relatively little of that is actual profits of health insurance companies, but it's something that certainly has received a lot of attention. And a lot of this money is also going to pay for sort of the back end of helping to manage individuals. So, for example, making sure that you have the infrastructure to be able to track all the diabetics in a panel and sort of reaching out to them, following what's happening, making sure that there's coordination among providers. Actually, all that costs a lot of money. You're not actually paying the doctors to do all that, and it costs a lot of money. So there's some worries about whether this is a good thing or not, actually, having this 85% cap. And so there's some debates back and forth. But thus far, in 2012, since this was implemented, about $1 billion has been rebated back to people who had been paying for health insurance for policies that didn't end up spending 85%. So that's a sort of pretty good chunk of change. Now, in a $3 trillion healthcare economy, right, that's just rounding error, but it's non-trivial, okay, so especially for the people who receive those funds. In January 2014, next January, that's when the big deal is going to happen, okay? So we are going to have health insurance purchasing exchanges, which are going to launch. So in California, this is called Covered California. It's taken a couple of years to create all the infrastructure so that we hope that this can launch in a smooth way. No doubt there are going to be many hiccups. These are incredibly complicated to structure, but the idea is this will be something like Travelocity. You can go onto a website and you can look through the different options for health insurance, and the health insurance plans across different health insurers are going to be relatively standardized, not perfectly standardized, but much more so than they are today. So you can attempt to be able to compare apples to apples, two different health insurance policies from different insurance companies. And individuals, any individual in the state will be able to go and purchase a health insurance policy at some pre-stated rate, a rate that won't depend on that individual's health status, will depend on their age and sex and where they live, okay, but not depending on their health status. So this health insurance purchasing exchange is going to go live in January 2014. There will be one exchange for individuals, another exchange for small businesses to be able to purchase health insurance for their employees. At the same time, we're going to have a pretty substantial expansion of Medicaid coverage for low-income individuals to be covered by insurance with the government paying for that that full premium. So we are going to go up to, now people up to 133% of the poverty line are going to be covered under health insurance. So today, the poverty line for a family of four is getting up close to sort of $25,000 or so. So people sort of making up families of four with their income is up into the low 30s or so are going to be eligible for Medicaid. Today, kids in California are already getting covered, but their parents are not covered. Essentially, most adults are not getting on to the Medicaid except in sort of very special circumstances. So this is a pretty major expansion of coverage for lower income individuals. Then, in addition, people above 133% of the poverty line, up to 400% of the poverty line, so getting up close to a family income of $100,000 for a family of four, are going to get some kind of subsidies to help them pay for health insurance. Okay? And we'll sort of talk more about that as we go. Then, in addition, what's going to kick in January are mandates for individuals. Every individual, with a few exceptions, is going to be required to have health insurance coverage. So this is a big change. If you believe that there are a lot of people out there running around who just feel either feel as if they're invincible, nothing's going to happen to them, or they just want to take a gamble and not have to pay health insurance premiums until something happens that's really bad and they land in the emergency room and someone else pays the dime. Well, if you feel like there are a lot of people out there, then this is a fair thing to help them sort of pay their fair share finally. Okay. If you're worried that there are a whole lot of sort of lower income people who just aren't going to be able to afford this, then this is a bad thing. Or from a sort of libertarian point of view, why should the government be telling you how to spend your money? Right? So there are different sort of points of view about this. Similarly, there are certain mandates that we're going to have for employers. Right? So this is just sort of a broad overview, and I'm going to come back to a couple of these different sort of most salient pieces. But before we do that, let's step back and think about, so what is it that we're really trying to do with this sort of health reform bill? There are a couple different potential goals that you can have. But before I do that, let me sort of acknowledge that there is still a great deal of differences of opinion in our society about the Affordable Care Act or about Obamacare. So here is a time series of polls going from April 2010 up through so the end of 2012 of responses to a question. As you may know, a health reform bill was signed into law in 2010. Given what you know about the health reform law, do you have a generally favorable or generally unfavorable opinion of it? Okay? And so we can see the two lines, say the favorable line here and the unfavorable line down here, sort of intertwining. And essentially, we have a split public opinion. And depending on the exact month that you want to pull, you can have a press release saying support declining or support increasing. But basically, we have an incredibly divided country still about the health care reform law, and that's sort of important to acknowledge. It's useful to realize, though, that of the people answering this question, the majority actually tell us that they don't understand anything about the ACA. So we have a great deal of misinformation out there still about what is in the ACA or sort of lack of information. So, on average, 57% of people are telling us, no, they don't have information to really understand how it's going to affect them. And I like to think that that's why a lot of people come out to forums like this, but I suspect that a lot of you know an awful lot about it, and you have very strong opinions, and I'm looking forward to the Q&A session towards the end so we can hear some of that and have more interactive discussion. All right, so different goals of health reform. So the number one goal for the Obama administration is to tackle the uninsurance problem. Okay? So that is how this bill was structured, to tackle that particular goal. Now, that particular problem. Now, along with that, there's a great deal of interest in improving equity in the health world. So equity in access to health care, equity in the financing of health care. So who's actually sort of paying it? Are you forcing the people who are already sick to have to pay much more for their premiums or not? People also talk a lot about wanting to improve health outcomes, but I will argue that on a population basis, this law is really not health reform, it's health insurance reform, okay? we're not going to see life expectancy in the U.S. changing overall as a result of this particular bill. For those individuals who are receiving health insurance who are previously uninsured, this will clearly benefit their health. And this has been documented, time and again in many different dimensions, that people who are uninsured have worse access to care. They access care later when they have some severe problem. They present in a later stage of cancer, et cetera. They die at a higher rate. But given, say, the number of individuals in the aggregate who are actually going to get insured relative to the total population, we're just not going to see those life expectancy numbers move. So it's well known that U.S. life expectancy is lower than sort of much of Western Europe. We're not going to see the U.S. catch up as a result of this. As much as people sort of talk about that being sort of an important goal, that's simply not how this was structured. So to an economist, health insurance is not about improving health. Health insurance is insuring you against catastrophic risk. Okay? So when President Johnson signed the Medicare Medicaid legislation back in 1965, what did he say? Did he say, I'm signing this so that we can have better health in the United States? No, he didn't. He said, I'm signing this today so that we can prevent catastrophic financial losses by our seniors and their families. So that is the big win when you expand health insurance, is that you're helping to prevent those sort of catastrophic financial losses. Then I haven't talked much yet about healthcare cost growth, which is incredibly fast in this country, and in fact in many other countries around the world. When I talk to some of my Republican colleagues, generally this is what they want to see focused on in healthcare reform. They say we need to fix the healthcare cost problem, the growth of healthcare costs. If we can fix this, we can have a hope of tackling the uninsurance problem. Right? So this is part of the sort of political discussion and the sort of political debates about the ACA. Do we tackle the uninsurance problem first, and then once we get everyone in the system, then we try to exploit that sort of fuller system to find ways of slowing healthcare cost growth, or do we really tackle the cost growth problem so that we can have money to tackle the uninsured? And in fact, one of the underlying reasons why we're seeing more and more people uninsured is because the costs of health insurance are going up and up and up. And if we can have a hope of tackling this, then maybe we can get at that problem. So as it happens, it was the Obama administration who was able to tackle healthcare reform. And so we're seeing it was the uninsurance problem which sort of went first. So does anybody know what proportion of sort of Californians, say under age 65, so the non-Medicare population, what proportion are uninsured today? 18%? That's a pretty good guess, yeah. So these are data from the California Healthcare Foundation that I pulled. We see that in the U.S., sort of averaging across 2009, 2011, a few years, during the recession, it sort of bumped up. So we've gone up to about 22% of Californians, the 7th highest uninsurance rate in the country. We see Texas has the highest, up at 27%, but California is not smelling very good. Okay, so we have a very serious uninsurance problem in California. We can see that over time, this is a graph that shows uninsurance rates from 1987 up to 2011 in California. It's increased from about 18 to 22% over the last 25 years or so. And in the U.S. as a whole, it's increased from about 14 to 18% in the U.S. as a whole. So it's this steadily increasing problem. Right? It's not just a problem of the recession. A lot more people get uninsured, although the recession sort of made it worse. But we're seeing this trending up and up. I mean, it's not like it's going up by 10% a year, but it's pretty substantial. The top couple lines are looking at the proportion of the population who has insurance through their employer. That's the dominant way that people under 65 in this country get their health insurance. But we can see that in the U.S. as a whole, that's decreased from 70% down to 58%. In California, it's gone from 65% down to 52%. So this rapid drop in the proportion of people who are getting insurance through their employer. Now, part of this is because we've had an expansion in Medicaid and public programs. So that's a good thing for all the people who were previously uninsured. For those individuals who previously had employer-based insurance are now switching to the public insurance. Either that's a good thing because it's allowing them to have greater take-home pay, or it's a bad thing because our taxes have just gone up, depending on how you want to look at it. So the public coverage in California has increased from about 16% 25 years ago up to about 23% of the population now. So almost a quarter of the population under 65 are on sort of some kind of public insurance program. And we have a sort of parallel decrease in private coverage going on at the same time. A lot of this on insurance is linked to the size of your employer. Okay? So if you work for a large firm in California, about 17% of those employees in large firms are uninsured. If you work for a firm with fewer than 10 employees in California, about 42% of those individuals working for a small firm in California are uninsured. So why is that? Why is it that folks working in small companies are much more likely to be uninsured? It's expensive. Wasn't it expensive for these guys? Okay. So there's some pooling that goes on in sort of large firms. And really by pooling, what we mean is that if you're in a small firm and everybody's healthy, actually you have insurance premiums which are pretty darn good. Okay? They may not be quite as good as what you get here where you have lower administrative costs because it's sort of cheaper to administer sort of one large plan to lots of people. But it's, it's pretty good. But if you have one sick employee in your small firm, then your premiums are going to get written up. And they can get written up to the point where the firm just says, well, forget about it. We're just not going to get health insurance. This doesn't make any sense. You guys, the 9 of you who are healthy, you go out and buy insurance on your own. And you who are sick, I'm really sorry, but go find a large employer to work for. So this is one of the problems in the current health insurance market that the ACA reforms are intended to tackle. Right? This sort of disparity in the access to sort of affordable health insurance, depending on where you work. We also see, as expected, and this is just to sort of quantify it, that higher income individuals in California, those making $75,000 or more, only 9% of them are uninsured. Those who are making under $25,000 a year, more than a third of those are uninsured. That's a really high uninsurance rate, okay? And that's something that many people feel is a real sort of moral issue in our society, that every other high-income society in the world has found a way to address this, and in the U.S. we haven't. It's useful to look at the eligibility for health insurance programs in the U.S. We see that among adults, we only have about 6% of if you take the sort of top left number there in California, this was as of a couple of years ago, there were sort of about 6 million uninsured adults aged 19 to 64. Of those, about 6% of them actually were eligible for the Medicaid program in California, Medi-Cal, but they just hadn't bothered to get signed up. But most of them are just not eligible for the program at all. Among children, we only have 1 million or so uninsured children in California. And actually, more than a third of them are already eligible for Medi-Cal, and another third of them are eligible for the Healthy Families program, which is for slightly less poor families. So actually, only a third of them are ineligible for a current public program. So we actually have programs out there for kids. We haven't done a very good job of getting them signed up. So one of the real issues that the health reform is trying to tackle is how do we create those systems so we get people signed up so that they know they have access to the preventive care, et cetera, and they don't just wait until they get really sick and then walk into the ER and then someone says, oh, by the way, you were eligible for this all along and we'll get you signed up. So if we take into account some of these different factors about income differentials and who's actually eligible for care, here's a slide that reflects uninsured population as of 2007. And this is a slide that is circulated by my Republican colleagues. So I served in the White House Council of Economic Advisors under the George W. Bush administration. And this is essentially the argument that was used by the folks in the administration at that time for why we're actually not as concerned about the uninsurance problem. And I'll let you draw your own conclusions about how you feel about all of this. But it's useful to sort of understand how different folks are thinking, as I find that typically among my students at Cal, and probably reflective in this audience, there are more people who are here because they care about the uninsurance problem. But we like to make sure that we understand how other folks are thinking. So, but if you take the 46 million uninsured in 2007, of those, about 6 million of them actually are already on Medicaid. It's just that when we calculate our usual numbers about uninsurance, it's these sort of surveys someone calls up during dinner time and they say, do you have health insurance? And they say, well, I don't know, no, go away. And about 6 million of them, we know from administrative data, actually had health insurance, even though they said no on the phone. Now, it may be that they actually don't know that they have health insurance, which is a problem, or it may be that this is just statistical error. So that would suggest, well, really, there are only about 40 million or so uninsured. And then there are another 4 million or so who are actually eligible for current programs such as Medicaid, but they haven't bothered to sign up. So either they don't know that they're eligible, or they just haven't gotten sick, and so they haven't bothered to because we've created so many hoops making it hard for people to sign up and stay signed up. Okay? If we think, well, we already have a system out there, so now we're down to 36 million. Of those 36 million, about a quarter of those are immigrant populations. Now, this was a time when the Republican Party hadn't jumped on the immigration bandwagon yet, as immigration being something that is sort of being embraced by the party is happening very recently. And sort of all non-citizens were sort of lumped into a group, be they long-time green card holders, be they sort of recent documented immigrants, or be they undocumented immigrants. They just said, well, if there are immigrants, then they're not our primary responsibility. Okay, so this was the attitude. Of the remaining, about 10% are over 300% of the poverty line. And the argument was they should take care of themselves, right? We don't need to have a big tax program to pay for health insurance for these people. Because over 300% of the poverty line, that's actually over median income, roughly. So you would be taking someone who's in the top half of the income distribution in the U.S. and saying, well, we need to somehow subsidize them. And within the administration at that point, they said, well, no, that isn't the highest priority use of our dollars for social programs. Of the remaining, there are about 5 million who are childless adults. The same thing. The argument was these people should be taking care of themselves somehow. Now, again, forgetting about the fact that a good chunk of these have sort of mental health problems, homeless, substance abuse, et cetera. So they ought to take care of themselves. So what we have left is about 10, 11 million who are the hardcore sort of uninsured, who the administration at that time really said, this is who we need to take care of. It's about 3% of the population. We don't need a $1.7 trillion bill to take care of the 3% of the population. Right? So that was the argument. What they said is, we need to figure out ways of attacking the healthcare cost growth problem first, and that should be our sort of top priority. So, I will sort of, again, leave it to each of you to apply your own values to these different numbers and who society ought to care about. So just in that vein, this is from a survey that was during the healthcare reform debates, before the ACA was signed. And we see, as expected, that responding to a question how serious of a problem is it that many Americans do not have health insurance? Well, 55% of Republicans said it's a very serious problem, 94% of Democrats. And of the 55% of Republicans, if you ask a follow-on question, well, would you be willing to pay X dollars to tackle this problem, then that sort of goes down and down. But, over half said that, it's a serious problem. But, again, this is just sort of more evidence of the huge divide that we have in this country around these issues. And it's a divide that's going to continue. So, Obama won the most recent election, and so the ACA is going forward and being implemented as best the Obama team can do. But it's likely that within a few years, 1 or 2 election cycles, we're going to have a Republican sitting in the White House again, and a lot of the pieces of Obamacare can actually be slowly sort of dismantled and watered down. And so we are going to see this argument continuing for many, many years. Right? This was not, now we fixed it and we can all go home. So let me ask you another question. Can someone give me a guess of how much health insurance costs for, say, a family health insurance plan if you buy it through your employer? So what's the average total cost of that health insurance plan when purchased through an employer? Not just what you as the employee pays, but the whole cost of the plan, what both you and the employer are paying together. Anyone have any idea? $1,000 a month, $17,000. It's $3,000 a month. Too much. Okay, there we go. I think most people would agree with that one. So here are some data on that question exactly. So this bottom line is showing for a family of 4 the average cost of health insurance that's purchased through employees in the United States as a whole in 2012. Over $15,000. Now, this is employer-sponsored health insurance, not purchased on your own. This is per year, not per month. Yes, this is per year. So this is, no, the $15,000 was the cost just in 2012. These numbers not inflation adjusted, but nevertheless, there has been a huge growth in this underlying cost, right? So this is one of the reasons which is driving why we're seeing the uninsurance problem getting worse and worse over time. It's just costing more and more, and more and more people say, just can't do it. Now, most people don't see the $15,000 price tag because the typical employer-based plan, the employer pays 2/3 of that cost, or 70% of that cost, by withholding the dollars from your take-home wages. It's not the employer who's paying for it. Right? In an accounting sense, they write the check, but the money is coming out of the employee's pocket by reducing their take-home wages. Okay, so it's really costing the employee $15,000, how much more they would have gotten if they had gone to some other employer who wasn't offering health insurance benefits. I mean, you can see these differentials in the labor market. But it's really incredible. And for an individual, even, it's over $5,000. So if you're at minimum wage, okay, let's say you're a single earner at minimum wage, and you're trying to buy a policy for you and your kid, well, congratulations. You can maybe, depending on whether you live in San Francisco or somewhere else with a lower minimum wage, you can maybe afford health insurance and not buy anything else in the whole year. Okay? Just the math doesn't add up for people. We can see another way of presenting this is the trend since 1999 in the healthcare, in the increase in premiums. And we see that the premiums have gone up by 170% over this time period. Inflation has been 38% over this time period. So this is real increase above inflation. This second line here is workers' earnings, so the average earnings. So they've gone up just above inflation overall. If we take out the highest income workers, if we look just at median income, it sort of tracks inflation pretty much. And median income hasn't really moved over the last couple decades in the US. But what we're seeing is that the healthcare costs are going up and up. So one of the reasons why the median income, your sort of take-home paycheck, hasn't gone up is because your health insurance is eating a bigger chunk of your total compensation. So that's just going up, sort of as fast as your productivity might be going up, and so your take-home pay is sort of flat. So what is it that the ACA is doing to try to address all this? Well, it's only going to be addressing part of it. Again, it wasn't a reform about tackling the healthcare cost increase problem per se, but it was really about let's fix these problems that people in small businesses have a hard time getting health insurance if someone's sick. An individual has a hard time getting insurance if someone is sick. And we have this sort of huge uninsurance problem. Well, the core of health insurance problems, so the first principles that President Obama stated very early on was that he was going to retain the current employer-based system. So we have single-payer advocates who wanted the entire system to go away. And then we had a lot of people who said, well, great, we want to help those, that subset of the population is uninsured, but don't mess with what I have right now. And he said, okay, it's a big enough lift to try to help those people who are uninsured, so we're not going to try to totally destroy the entire system. So we'll retain the current employer-based system. We're going to add these purchasing pools to try to pool together all these uninsured people and have some state entity, some state insurance purchasing pool, negotiate with insurers on those individuals' behalf. So each individual can just go to this sort of state health insurance exchange, this Travelocity-like thing, and pick out an insurance plan. So it's supposed to make insurance plan choice easier and smooth the risk. At the same time, the ACA also tried to expand choices, insurance choices, by seeding new efforts for nonprofit health insurers, because there's been so much rhetoric about the big bad health insurers' profits who are sort of eating up the healthcare system. So first of all, sort of overall sort of insurance sort of overhead, et cetera, it's only about 6% of the U.S. Total healthcare bill. I say only. It's a huge number, absolute number, but it's not the dominant portion of U.S. healthcare spending. Okay, so the idea that it's the health insurers' profits who are driving all the ills in our system it doesn't really hold water when you sort of look at the absolute numbers. Furthermore, the majority of people who are insured with a private insurer in the U.S. actually are insured through a nonprofit health insurance company already. You didn't really get this through a lot of the health reform debates that were all about the big, bad, and evil health insurance company that was sucking profits out and causing prices to go up. That's actually not really a sort of valid rhetoric. So, as we talked about, so the key piece of this for expanded insurance is to subsidize those insurance purchases for low-income individuals and also for small businesses. Okay, so this was a sort of large political win in the U.S., the idea that we want to promote apple pie and we want to promote small businesses, so we're going to give preferential treatment to small business. Whole other talk about whether that's a good thing or not, but that's sort of in the bill. And then we have the new regulations that we talked about that insurers must insure everyone who walks in their door, regardless of their health status, and they must charge the same thing to everybody, regardless of their health status. So that's a major change in the health insurance marketplace, especially in California. A handful of states already had this, but most states did not. And some of the states that already had this, such as New York, actually have seen a very dysfunctional private insurance market. So New York, a number of years ago, said that we are going to ban insurers from charging different amounts based on health insurance status. And what do you think happened? Okay, so anyone who was uninsured, who was sick, said, whoa, my premiums just went way down to some average amount. I'm going to buy insurance now. The insurance companies saw the amount that they had to pay out in medical claims go way up, so they said, oh, time to raise insurance premiums so we don't lose money. And some of the healthy people said, oh, I'm perfectly healthy. Why should I pay this? The insurance premium is going up and up. And we see what's called an adverse selection risk spiral, where the premium's gone up and up and up. And so my sister lives in New York, and her husband is sort of independent sort of contractor, and so they buy insurance through this individual insurance marketplace, and they pay premiums north of $25,000 a year for their family. All right, this isn't just for some special, super duper Cadillac plan. This is sort of a typical PPO kind of plan, which is out there. Right? So there was a lot of concern by the insurance companies that once we went to do this, it's a great thing, it polls really well, but it's only going to work if we keep everybody in the system. Hence, the mandates. So the individual mandates, okay? Requiring everyone to stay in the system, as well as the employer mandate. So let's talk about the individual mandate. There's been a lot of heat about the potentially sort of onerous cost to some individuals who are going to get penalized if they don't buy health insurance. Well, how big are those penalties? The first year, in 2014, they're designed to be very small, right? Not to be onerous, to give people time to sort of figure it out and get into the system. So in 2014, individuals uninsured is going to have to pay a $95 penalty on their income tax return, or 1% of their income, whichever is higher. Okay, so if they're actually a high-income individual and they've been free-riding off the system, not paying into the overall risk pool, somehow on the idea that they're not part of the system, and we know that every one of these individuals is going to get sick and walk into the ER, and someone else is going to pay their bill. Right? They've been free-riding essentially. So those individuals are going to have to pay more. By year 3 of implementation, 2016, it's going to go up substantially to $695 per adult, half of that for each kid in the family is uninsured, or 2.5% of the household income, whichever is larger, up to a maximum of just over $2,000 per family. So $2,000 per family is not $15,000, which is what the total cost is with your employer. But in most employer policies, the individual would only pay $4,000 or $5,000 a year. So if now you're choosing between paying a $2,000 penalty and going uninsured, or paying for a $5,000 penalty, $5,000 health insurance contribution towards your premium, well, actually, a lot of people are going to decide, I'll take the insurance now. There are going to be some people who don't go into the system. There are all sorts of estimates of how many people are actually going to end up penalized, who are going to try to stay out the system and not. We have absolutely no idea, okay? You'll hear all sorts of papers who are going to say, well, under these assumptions you get this, under this assumption you get this. We have no idea. We'll find out a year from now. If you're interested in your own situation and you want to see what your penalty might be, there's a calculator that's been put out there by the Kaiser Family Foundation at healthreform.kff.org, where you can put in some of your own individual information. So we just talked about, so the key reason why we have this is to counter adverse selection, and some people would argue it's to promote universality of coverage, but there are certainly the downsides. There's the standards for the libertarian objection that the government shouldn't be telling us how much money to spend on broccoli, et cetera. And these were all the arguments that were made in front of the Supreme Court. Ultimately, it was Justice Roberts who said, well, this is really just a tax. It's not necessarily a penalty. It's the same thing as a tax to help pay for that health care that we know you're going to get when you walk into the emergency room. And so the libertarian objection is it has to be a much more extreme one if you're going to object against one more tax. But the key problem is that you can't tell someone who makes $20,000 a year that they now have to spend $15,000 on health insurance, right? That would be unethical, immoral. So what do? Well, we're going to expand Medicaid, as we talked about, up to 133, or you'll see both 133 and 138% of the poverty line referred to. They're actually recalculating how we're calculating income for these purposes, and that's why you'll see two different numbers. So a lot more people are going to be eligible for Medicaid. And then if you are making between 139 and 250% of the federal poverty line, then on a sliding scale basis, there is going to be a cap on how much of your income you're expected to spend towards your health insurance premium. Okay? And that cap will determine how much of a subsidy you're getting. So the subsidy will be adjusted for each individual. So right at 139% of the poverty line, you're only expected to pay 3% of your income. And so they take the price of the sort of cheapest plan available through the health insurance exchange, and they figure out what your income is, that 3% is, and they will give you a subsidy for all the rest. And that's on a sliding scale up to, by the time you get to 400% of the poverty line, then you will have to pay up to 9.5% of your sort of income. And if the lowest premium available is more than 9.5% of your income, then you will get a subsidy to pay for that remainder. Okay, so there is this sort of sliding scale to make sure that we're not sort of putting ourselves in this unethical situation, and we're forcing people to spend all of their money on health insurance. So as a result, there's actually a really complicated dependency of who's going to pay penalties depending on one's income. And this hasn't been really sort of out there in the newspaper a lot. So let me just spend a minute talking about this graph. So anyone whose income, this is a graph for a sort of typical family of four who has a sort of 40-year-old sort of head of household, so the primary policy holder. If their income is up to close to $20,000 or $25,000 in that range, they're not going to pay any penalty. All right, so they're just sort of exempt from this, and in fact, most of those will be eligible for sort of Medicaid. There's another chunk of people who make between $100,000 and $150,000 a year, whose income relative to the cheapest policy isn't high enough. Okay, and so they're going to be exempted from the penalty. So they're, even if they were buying the cheapest policy, they would have to pay more than 8% of their income towards their health insurance premiums. And so if they choose not to buy health insurance, then they're going to be exempted. So if you're forced to pay more than 8% of your income on health insurance, because that's the cheapest premium available through the exchange, then you don't have to pay a penalty. So we're going to see a whole bunch of people between $20,000 and $100,000 if they choose not to get health insurance, even though they're getting these big subsidies that depend on their health insurance, they are going to get penalized. And then after about $150,000 a year income, then these people are going to get penalized if they choose not to. And this will depend based on the exact premiums that we actually see in the marketplace. But it's actually sort of much more complicated than sort of the usual narrative that you get. And again, if you want to know about your situation, go to that sort of health reform calculator, and you can find out. Now, this is sausage making par excellence, right? This is what happens when we have committees sort of trying to make up these health reform laws. It's not necessarily what any one individual would have chosen, but this is a series of compromises. This is what has resulted. All right, so then we have the employer mandate. So let me just talk about the employer mandates for a minute. If a firm has fewer than 50 employees, then there's going to be no employer mandate. They don't have to provide health insurance. There's no penalty if they don't provide health insurance. Okay, so again, we've given preference to these small companies, the apple pie companies that we have this sort of lore that this is who we need to give preference to. If a firm has more than 50 employees and they don't offer insurance, and at least one of those employees goes to the health insurance exchange and gets a subsidized policy, then the employer is going to get penalized. And their penalty is going to depend on the size of the employer. Okay? So for each employee over the first 30, so you get sort of an exemption for the first 30 employees, but after those first 30 employees, each additional employee that you have, you will have to pay a $2,000 penalty per employee. Okay? So more sausage making in that formula, but that's what it is. And it's designed to give sort of strong incentive to firms to continue providing health insurance. Why? Well, politically, it's a lot easier to require firms to pay for health insurance for employees than to raise taxes even more to provide additional subsidies to more people out there in the marketplace. And we saw this, this was sort of the Democrats were pushing this, but we saw this in the Schwarzenegger administration back in 2007 in California when we were involved in deep conversations to have health reform, and this was the sort of shared responsibility, right? So this is sort of bipartisan effort to require employees to continue providing health insurance. The big concern that you hear people talking about is that this is potentially job killing. So is this going to actually hurt the economy? So is this going to cause firms to either hire fewer people or to go out of business? If there is a huge adverse economic effect, then we would really need to think twice about this. But it's an empirical question how big this is. And frankly, the weight of the research, my interpretation of it anyway, is that there's likely to be very few lost jobs as a result of this. And I've been studying this in San Francisco, which put in an employer mandate back in 2008, essentially for all employers to have to provide health insurance for their employees. And we sort of documented what's happened to employment in San Francisco relative to places outside of San Francisco or relative to other cities around the country. And there's no evidence that jobs were lost in San Francisco because of this requirement. And I think that the same is likely to hold true nationally, that there's a lot of heat about this being job killing, but really there's just no evidence for it. Another concern, which has not been articulated as much, is that in the long run, it's not the employers who are paying for this health insurance coverage. It's coming out of individuals' total compensation. So like we talked about before, I mean, it's, as much as we like to think it's employers who pay for it and they write the check, it's coming in at the cost of sort of lower wages. So it's actually sort of less progressive to require employers to cover health insurance than it would be to have all of these people going into the same public program, and we give sliding scale subsidies to those individuals who are deemed to need them, and no subsidies to others. But that's not something that's been focused on. And another potential con is that this is really, again, preserving this employer-based system, which in many ways is just so dysfunctional. And many people will tell you if they could go back and start the system over again, they would not tie health insurance to your employer. But that's the system that we have today, and it's hard to get from here to there to something else. All right, so what is the end result of all of this that we've been talking about? Well, the Congressional Budget Office, their latest estimates, after the Supreme Court decision which allowed some states not to expand Medicaid, so the latest estimates are that nationwide by 2016, when we have this sort of phased in, we're going to go from 57 million people who would have been uninsured in the absence of this health reform down to 31 million people uninsured. Okay? So 26 million people are going to get insurance who otherwise would not have had insurance. Right? That's a lot of people who get help. A lot of people who get help by health insurance. A lot of people are left out. Okay? So who is it that's being left out? Well, in California, we're seeing this go from about 6 million down to 3 million uninsured. Among the remaining uninsured, about half of them, roughly, are immigrant populations, both undocumented and documented. Because documented immigrants also are not allowed to get subsidies. They're not allowed to buy into, they're sort of not benefiting from the health insurance reform. Among the remaining uninsured, you're going to have some folks who are exempted from the individual mandate because their income is not high enough to really be able to pay for the cheapest policy, and the subsidies aren't sort of big enough to induce them. And then we'll have various folks that, for whatever ideological reason, they decide that they don't want to buy health insurance. Right? So we have a big uninsurance problem remaining in this country that we're still going to need to find ways to deal with. They're still going to be walking into the emergency rooms. We're still paying for them in many ways in our system, but they're just not insured. All right. Let me just sort of keep going in the interest of time here. I'm going to wrap up in just a minute. So what is this costing us? Okay. Congressional Budget Office, again, the most recent estimates that they've released, the 10-year cost of this is that we're going to be spending about $1.7 trillion, trillion with a T, on various subsidies to help people get health insurance now. So about half of that are going to be the subsidies for people to buy health insurance in the exchanges. Roughly half of that is going to be the cost of expanding Medicaid the population, to the lowest income folks. Right, $1.7 trillion. How is this being paid for? Well, there's on paper $1.8 trillion in revenue, so it's supposed to more than pay for itself, right? It's reducing the deficit by $100 billion, right? That's the standard line. Well, where is this coming from? Well, about $500 billion is going to be coming from penalties of various sorts on people who don't buy insurance, on employers who aren't continuing to provide insurance, et cetera. About $600 billion of this is going to be paid for through new taxes. We've already seen the increases in some of our payroll taxes, et cetera. So that's where it's coming from. Another $700 billion are through spending reductions, and a good chunk of that are for decreases in how much Medicare is paying doctors. $400 billion. Okay, and so this is where we've been hearing a lot in the newspapers about how the ACA is sort of killing Medicare. Well, these are the same decreases that both parties have been talking about for years. It's just that it was a Democratic-sponsored bill who actually made them go forward. What's really unclear is whether those decreases will be sustained politically. So when push comes to shove, as those reimbursements sort of go down, will someone say, well, no, we need to keep the money in there. My lobby group X, Y, or Z is telling us we need to do this. So maybe those will disappear. It's also the case that if any group had wanted to decrease these reimbursements, they could have done this without paying out $1.7 trillion in subsidies. If you just wanted to find more ways of plugging to the deficit, dealing with the deficit problem in the US, they could have just passed this. Now, politically, it's really hard to pass this in the absence of everything else that's going on. This is sort of part of a big package. But that's what some people will argue. As to put this in context, the Bush tax cuts back in the early 2000s lowered revenue by about $2 trillion over 10 years. Okay, so this is a lot of money, but it's sort of less than what the sort of Bush administration's did to the overall deficit. So I've been sort of going on for about an hour, and I could go on for another few hours, but I think it would be more interesting at this point for me to sort of stop talking at you and talk with you. So I'm going to open this up for questions, and I'd love to hear all sorts of different questions and comments that you have. So yeah, please use the microphone because this is being videotaped.
Can you address the pre-existing condition for adults, and will that be gone?
So under current law in California, for example, if you buy insurance through the individual marketplace, you will get charged a higher premium if you already have a pre-existing condition, or you may not be offered insurance at all. Under the reforms, insurers will no longer be allowed to treat people differentially based on pre-existing conditions. In 2014, that will take place for adults. Something, again, that sort of polls very well consistently that is something that many people in the American public wanted to see. Yes?
You had said that the health care costs are rising in this country, if I heard it correctly, independent of the insurance companies. And can you elaborate on what's causing these costs to go up, please?
Okay, so let me just show you a quick graph of healthcare cost increases overall in the U.S., just as context first. Back in 1960, the U.S. spent about 5% of its GDP on healthcare. We got into the 1970s, and it went up to 7, 8, going towards 9%, and people said, oh my, the sky is falling, this can't continue. This is destroying our economy, and something has to happen, otherwise the world's going to end. Well, here we are at double that, 18% now, and it's projected to keep on going up and up and up. Okay. Now, what is causing this? It's not because insurers are somehow getting a bigger and bigger chunk of the healthcare dollar. No, their proportion of the healthcare dollars isn't going up and up and up. That's not causing. It's not because medical malpractice premiums are causing a bigger and bigger chunk of this. No, that's not causing it. Aging. So part of this is due to the aging of the population. And in particular, some of the projections are that it's, we sort of get out into the next couple of decades, it's going to go up extra high, but it's going to keep going up and up and up. It's not just the aging either. And one of the underlying things that's driving it is we're getting richer and richer as a society. And so as we get richer as a society, we want to spend more and more of our dollars on improving the quantity and quality of our life. And we can do that through buying a third car, or we can do that through investing in medicine. And it actually makes sense as a society that we're going to be spending more and more of our dollars on healthcare. And that's probably a sensible and a rational thing in a society to do. Now, if we look in an accounting sense, where is the money being spent? Well, more than half the dollars are being spent on sort of new technologies that didn't exist before. Now, some of these are new technologies that just aren't worth the money, and we shouldn't be spending the money on that. But a lot of them are actually really helpful to our quality of life, to our health status. If we think just about cardiovascular care, the advances that have occurred in cardiovascular care in the last 50 years can explain several of the years of increase in life expectancy in the US. So, how many people would like to go back to 1960 and pay 1960 health insurance premiums yourself, and we only spend 5% of our economy, and when you walk into the hospital, you get 1960 health care? No. So, health insurance spending is going up and up and up, okay? Some of that is really inefficient. We'd like to find ways of squeezing out those inefficiencies. Now, if we squeeze out those inefficiencies, what that's going to do is lower each one of these bars. And that's a good thing, and it frees up resources in our society for other things. But we're still going to keep going up and up and up. And we see all sorts of countries throughout the world sort of going up and up and up at the same rate. Yes?
The IRS has a ruling about tax-exempt hospitals or hospitals retaining a tax-exempt status if they have their emergency room free when people go in as charity cases. I'm not quite clear on how that goes, but that's a quick, rough statement of it. Would you say something about health maintenance organizations like the Kaiser system and how that would fit in? In other words, instead of just up and up and up, especially new technology, but improved health, like fewer diabetes cases because of health maintenance and the emphasis on getting a handle on this.
Yeah, so there are a couple different issues there. And one is sort of nonprofit versus sort of for-profit hospitals. So you're making the distinction of sort of tax exempt and non-tax exempt. So I'm not a lawyer, so I'm not going to be able to speak to all the nuances of this. Generally, what we talk about is the distinction between the for-profit and the non-profit hospitals, where the for-profit have to pay various kinds of taxes that non-profit hospitals, not for-profit, sort of legally established as not for-profit entities, don't have to pay. And they're sort of tax favored. There's a lot of discussion about whether hospitals provide enough community benefit and charity care to justify that tax exemption. And that is sort of an ongoing discussion, because there are certainly some hospitals that provide a great deal of community benefit, and there are other hospitals who only provide a relatively small amount of community benefit relative to their what they're getting in tax breaks. And that's very sort of tricky political problem that people are engaging with. There's a second question there about health maintenance organizations. I think the inference is that there are certain types of care, preventive care, which is going to be invested in more in some settings than in others. And so how important is this investment in preventive care for tackling this healthcare cost problem? Okay, I'm in the School of Public Health. I'm very much am in favor of seeing expanded preventive care. So all the evidence that I see is that investing in prevention is a good thing because it's going to improve the health of the population. I'm also an economist, and as an economist looking at the numbers, I don't tell people to invest in prevention because it's going to save money, because it's not. Investing in prevention costs a lot of extra money in this system. There's a handful of things that I can tell you about that are actually investing in prevention that are actually going to save money on average. Because the problem is, for every number of cases that we prevent, we need to screen or do whatever, pay for some kind of prevention for millions of people. And that actually typically swamps the cost of actually treating those individuals. If we had just waited to treat those individuals when they got sick in the hospital, it doesn't cost as much as it does to give prevention to millions of people. And I wish that weren't so. But there are a handful of things which are truly cost-saving: smoking cessation counseling, flu vaccines, etc. But most of the things that we do, mammography, all that kind of thing, it actually costs us more money. It's still a good thing to do because it improves the health of the population, and that's valuable. And we can sort of quantify in a crude way, as economists like to do, how much that improved health is worth to us. And it's worth a lot more than what we pay in prevention. But that doesn't mean that it's actually saving money out of the system. So all the extra prevention that we're doing is contributing to the cost increases, but it's improving the health of the population, so it's a good thing.
There's apparently been a decrease in the rate of increase in healthcare spending. And if that continues, nobody seems to know why, but if that continues, what would that do to the 19.2% for your 2020 rate?
Yeah, so we've seen spending go up continuously, year after year. There was a time in the mid-90s when the rate of growth of healthcare spending was slower. This is as HMOs were sort of expanding and having sort of more bite. So there was a temporary slowdown in this, and then really what it was doing, it was squeezing out some of the inefficiencies, as HMOs sort of found ways of squeezing it out. And so all of these curves are a little bit lower than they would have been otherwise, because even though there's been a backlash against HMOs, we have fewer HMOs, a lot of the things the HMOs did have been incorporated by everyone else. And so that's lowered all of each one of these bars, but we're still going up and up and up. In the last couple of years, as you indicate, there's evidence that healthcare cost growth has slowed again. We don't know why. Some people will tell you it's because of Obamacare. Some people will tell you it's because of the economy. And truly, no one knows why. It's really too soon to understand what's driving that. If that is sustained, though, then that's a very good thing. Within the typical rate of increase of healthcare, we'll see going up by 6% a year, 8-10% a year sometimes for some categories of healthcare spending. And if that 6% goes down to 4%, then we will see spending be a little bit lower in those future years. The real value of that is if there's a permanent decrease in the rate of growth healthcare spending, we have a so-called bend in the curve, bend the trend of the healthcare curve, and as that accumulates and compounds over years, so decades, then that will make a real difference in how much we're spending as a society. So, in the next couple of years, it'll be meaningful, but you can't really see it on a graph like this. But over a couple of decades, it would be huge. The problem is we don't know how to do that. And there are a lot of people that will tell you, we have some idea for how we're going to cut spending out of this and that, and they're all charlatans, right? If they truly are trying to convince you that they know how to do it. People talk about investing in IT, information technology, that this could squeeze out trillions of dollars of waste over the decade. All the studies that have looked carefully at this suggest that, again, health IT is very important because it improves the quality of care, but it's going to raise our costs. So the most promising approach, which is incorporated in the ACA toward bending that trend and squeezing out inefficiencies, are the efforts to change the way that providers are being paid. Because today, most providers are still paid for volume. So the more stuff you do, the more you make. And there are efforts to put more incentives to capitate both doctors or provide just a single dollar amount for an episode of care. Okay, so if someone comes in to get a new knee, you're going to get X dollars, and if they need to get readmitted 3 more times because something went wrong with the operation, then it's your cost. If you use a really expensive medical device for the knee, then it's coming out of your dollar as the provider. And so there are much stronger incentives now to squeeze out some of that inefficiency. So there are examples of this actually working already, but really it's going to take decades of efforts before, on a widespread national basis, we're going to see the fruits of this. But it is, promising, and it's a long-term trend.
I'd like to go back to prevention a little bit.
Yeah.
So what if we define prevention as more like increasing nutrition counseling, weight loss, increasing activity levels, reducing their pharmacological dependency, and extrapolating that over time? Does that not reduce costs over time, especially?
So each
Instead
one of those things that you talked about is going to require some investment, okay? So
But
weight
probably
loss.
less investment
So if all I need to do is stand on a bully pulpit and I say to people, lose weight, because we know that people who are above some threshold are on average costing more in the system. If that's all I need to do to get people to lose weight, then it doesn't cost me very much money. Unfortunately, there are very few ways that we know of to actually encourage widespread sort of population changes in those behaviors. Okay, and most of them cost money. Now, some of these you could think about, cigarette taxation. We're able to do without actually incurring a lot of cost to society, and in fact, we generate revenue to society. You could think about having some kind of soda tax. That's something that, again, we could sort of generate revenue for society as we are trying to improve health. So those kinds of things can be done at very little net cost. But most of the things that we think about for improving nutrition are actually going to take a great deal of investment in finding ways to get people to have better nutrition. And if we could just snap our fingers and get people to do it, great. But we don't know how to do it. And I think that's really something that in public health, that's on us. We need to find ways to have that happen. And there's a lot of effort around that and promising things, but we don't have those magic bullets yet.
I wanted to ask you about our healthcare spending in this country versus what other countries spend, and the comparison of the outcomes, the general health of the population in those countries, and also the mortality rate.
Yeah, great question. So let me just start by showing you some of the trends over time of healthcare spending in the U.S. compared to a set of sort of other OECD countries. And we see that healthcare spending is going up and up and up in all these countries. But in the U.S., this top line, it's gone up much faster than in many other countries. Okay? So why is that? Well, it's not because we use the hospital a whole lot more in the U.S. In fact, if you look at hospital days per population, it's lower in the U.S. than in most Western European countries. Okay? It's, in an accounting sense, there are a couple things. One is we use care a lot more intensively. We use technology a lot more intensively. So when someone goes in, they're much more likely to be getting a lot of sort of intensive use of technology. And some of that is actually very good for the health of those patients, and some of that is sort of wasteful. It's also the case that in all of these countries, virtually all of them, there is much greater regulation of the healthcare system. And regulation in various ways, regulating technology, but also regulating prices. In the US, it is sort of anathema to think about the government's regulating prices system-wide. Medicare regulates some prices, and the VA system does some price regulation, et cetera. But the way that these countries have been able to keep down costs is through that sort of systematic bargaining agreements. It keeps down the wages of doctors, especially specialists. The ratio of specialist income to primary care income is sort of much different in much of the rest of the world. And so that all of this kind of regulation is the dominant reason why we see spending slower in these other countries. Now, tying this to health outcomes, it is also the case that most of these countries, probably all of them, I'd be careful, have higher life expectancy than the United States. Exactly. So that's the question, why? But is it because the U.S. spends more on healthcare? Well, it's not that the healthcare is killing us in the United States, but it's primarily because the money that we're spending on some of this less efficient healthcare is money that we've taken out elsewhere in our society. So if you were to ask me, what are the 3 most important things to invest in if we want to improve the health of the U.S. population? I would say, number 1, education. Number 2, education. Number 3, education. Right? So it is starting in early childhood. It is starting with policies that provide leave to mothers and fathers, right? Around prenatal leave, postnatal leave. It is investing in the early childhood development and education. It's meaning that this problem of a huge percentage of our young people in California drop out of high school. Right? And it is a really serious problem that we have such a huge dropout rate. And if you look at the longer-term determinants of health, it is going to be those underlying determinants are things like investing in schooling, et cetera. Now, we could say also that we have a lot of uninsured people in the U.S. that, as I said at the outset, doesn't really explain very much of U.S. health outcomes in the aggregate. Okay, so we're going to have, 8% more of the population insured once we go through this. So ensuring that 8% population isn't going to cause a huge difference in those international comparisons of life expectancy. But if we were to redeploy assets in the U.S. and spending and focus more on that underlying education, making it so individuals have the resources to live in a neighborhood that has fewer health threats, that there's less stressful pregnancies, et cetera, that's the kind of thing which, in the long run, is going to improve the health of the population.
This is very, very interesting shift in the curve. When you see all these European countries, the healthcare cost is less than us. In all these countries, they haven't had a problem with patients suing physicians. We, in this country, we sue the physician all the time. So the physician has to do the defensive medicine. I'm a physician, and I face this every day.
Yeah,
so
it's a very serious problem.
For me, there's no real healthcare reform without tort reform.
Yeah. So there are 2 aspects of this, as you allude to. And one is how much money gets spent in the system just on the medical malpractice insurance, et cetera. That's actually a relatively small dollar amount in the aggregate. In our $3 trillion economy, that's not very much. But the defensive medicine, so the extra things that get done to avoid a lawsuit, is much bigger. There are various estimates of this, maybe $150, $200 billion a year that we're talking about. So, maybe could be 5% of our healthcare spending is associated with defensive medicine. And that's from looking at states that have introduced different types of tort reforms and how defensive medicine has changed. But even if we were able to squeeze all that out, the U.S. would still spend way more than all of these other countries. So that alone doesn't explain why the U.S. spends a lot more. Now, having said that, if we could squeeze $150 billion of inefficient spending out of the system, that would be absolutely terrific. It's a hard political lift because the way that the trial lawyer lobby has essentially been large donors of the Democratic Party, and tort reform was not included in the ACA. Many people would say largely because of that, which is very unfortunate. And now hopefully when we have a change of administration, now that's one of the things that will get tackled. We'll see.
I'm sorry there's not time for more questions, but I want to thank Professor Dow very much for coming to speak tonight.
Thank you, everybody, for coming.
Please go out and enjoy the rest of the sunshine.